Respected Dr. Mangal Prihar sir, Dr. Vasudevan sir, Dr. Amar Soni, and my dear friends. I'm thankful to the ASAMI team for giving me prime time opportunity to share my work. I'm used to after lunch, second day hall B kind of talks. Today I am having the feel as if I am giving some oration. With these words, I like to share my journey of polio treatment. Dear friends, just starting how we do, I have made a video. Please go.
In a normal person, the limbs or limb, they are balanced. But in a poliotic patient, what happens? The deformities, they come. Might be of the knee, hip, foot, ankle, along with the muscle power. They just disturb the balance. Once the balance is disturbed, we calculate how much we can correct the deformities, and that much deformity with calculation we correct in the operation theater. We try to achieve almost full balance, which is once we come out of the theater post-operatively, functionally we match the performance. And you see, the rod is still not horizontal. So we have to take out a part of this. Then it still becomes unbalanced. We have to titrate it time and again, matching with the functional outcome and functional feedback of the patient. We increase the deformity, decrease the deformity, as well as in all the planes, also see the loading of the patient and then balance it. And this balancing more or less is very important till we get a horizontal balanced beam, balanced rod. This is, in nutshell, the treatment of poliotic lower limbs.
Dear friends, tea making is 5 minutes job, but it is an art. Similarly, burfi making is also an art. In burfi making, you have to keep on stirring for at least 1 to 2 hours. If you do not do that, then nobody will eat that. Elizro correction in poliotics is something like burfi, and correction of the deformities with plates and nail is something like tea, where you do everything in the theater without stirring. And if by the end of this presentation, I could change the perspective of the house regarding what they think about the treatment of polio, the purpose of this presentation is met with. I started the journey with plasters, and then we started doing Elizro and head support. Why? If the deformities they can be corrected in a simpler way like this, plaster, supracondylar osteotomy, no hand thigh guy after that, why should we opt for Elizro and head support? Dear friends, These are the three reasons. First is precision. If precision is not there, we can overcorrect the deformity or undercorrect it. So for this precision, we need Elizero and head support. Secondly, unwanted deformities in another planes, like varus, valgus, rotational issues, they can also crop up while we correct these deformities with the supracondylar osteotomy and plaster. So for these, and as well as whenever you are having multiple malorientation, malalignment syndrome like this, there are multiple deformities to be corrected, and these cannot be done with the help of plasters. You have to opt something like Elizero and head support. And the third thing is, if you add lengthening into it, then you have to opt for these things, Elizero and head support, without which with plaster you cannot do that thing. We started with only small X-ray of that part, AP knee and AP lateral. Later on, we shifted to full length AP and full length lateral. Then we opted for 3D CT scans. With these 3D CT scans, you can have the sagittal plane images of both the lower limbs. Frontal exact images, AP views, they can be got, as well as rotational issue of the femur and tibia, they can also be assessed. We also make 3D models so that we can understand the deformities in a much deeper sense and correct them. We are correcting these deformities before operation with the help of Bone Ninja now, as well as we are using Horus software with Mac. Few words about the hexapod. Hexa means 6, pod means feet or leg. There are 6 rods which are connecting 2 fragments. If we change the length of the rods, shorten them or lengthen them, the position of the fragments can be placed in the desired position relative to each other. Without hexapod, first you have to distract, then you have to apply hinges to angulate, then to translate, you need translation devices, rotational devices. With hexapod, all the above things can be done in a single go, in a simpler fashion. So, to understand that, if an ant has to go from the floor to the roof, first it will travel the floor, then it will go on the wall, then it will go on the desired position of on the roof. But if it is a wasp, it will directly go to the point of the roof by flying to the desired position. So with the hexapod, it is like wasp, and with translation devices, hinges, etc., it is just like an ant. Hexapod creates a direct trajectory from the present position to the desired position, which saves the time, simplifies the correction, and it is less strenuous to the regenerate. You will appreciate the applications in the next few slides. The spectrum of polio patients. And dear friends, no two cases are alike in their clinical presentation, and hence also they are not alike in their treatment. We daily come across such kind of patients, young girls, in the OPD of an orthopedic surgeon, and maybe having shortenings, maybe having age 45 years, who get tired. These kind of poliotists who have never touched the ground with the involved lower limb, and thigh gait, which is almost synonymous, gait with the poliotics, and thigh gait with the shortenings. Almost normal looking compensated gaits He's a doctor by profession and he wants to leave this stick. Very complex cases, as well as sticks, as well as the use of calipers. He wants to leave them. Uh, and age of about 59 or 60, they also want to be better. Dear friend, what do we do with them? We generally prescribe them certain vitamins, B12, calcium, etc., etc., yoga, physiotherapy, AFO, KFO, calipers, and most probably these patients, they do not turn up again. These are post-polio syndromes. What happens in post-polio syndrome? The number of steps start decreasing. The strength of the lower limb start decreasing. They cannot stand for long now. Hand-thigh gait is there. If it was not earlier, they fall down frequently. There's fatigue, back pain, bending while walking. And I advise them surgery. If after clinical evaluation and x-rays and studying the gait of the patient, I think I can give him a better life, which is functionally better. I advise them surgery, and this decision is very difficult to operate upon or not to operate upon. This young girl, she came to me. She had bilateral lower limb polio and hand thigh on one side. And I was, after completely seeing her x-rays, clinical picture, muscle charting, I was sitting with her and I was almost to announce that I do not want to operate upon you. She said, Doctor, if you think you can increase my functional ability by even 5%, whether I get that or not is a different issue. Please operate upon me. I thought 5% at least I will be able to do. Before the surgery, she could walk only for about 2 minutes, and after the surgery, she could walk for about 1.5 hours. So a lot depends upon the patients. There are so many factors which decide operate upon or not to operate. Mostly orthopedic surgeons, they discourage the surgery by saying you might get deteriorate. Somebody is befooling you. Muscles which once die in poliotics cannot be recovered. Do not get operated. Wear calipers, etc., etc. Yes, they are right. The muscle which die in polio cannot be recovered. But the bends in the limbs, they can be corrected. And limbs, they can be made functionally aligned. Sorry. To make the gait more energy efficient. Polio surgery is mainly for functional improvement and not for the looks. The principle is if the objects they are gravity friendly, they do not need support to stand like these stones kept one above the other. If they are gravity friendly, then they will not need any support to stand. And in this picture, you can see there are three ladies. One is on the extreme left. She is walking comfortably. She is a young lady. The one on the leading them is using stick sometime because she is about 60 years of age, and at this age her muscles are weak and very less deformities. So sometimes stick. The one in the middle is using stick almost very frequently because at this age the muscles they are weak as well as deformities they are there. So you have to understand why sticks are used, why bends appear, why the muscles they become weak. Lion is a very powerful animal, very strong, but once it tends to stand, the center of gravity does not pass through the base. The man who is very thin can stand. He only even can sport the lion because he is gravity friendly. This is the principle of correction in politics. One thing I like to share, most of these patients, they come, they say their foot and ankles, they are deformed. They can be seen very easily by patient, doctor, and everybody. And we try to treat them. Please go proximally. The knee is hidden, but this can be seen from all the sides if extra effort is in. So might be deformities is they are at knee. Still goes higher up, hip, which is hidden from the eyes and mind of both patient as well as physician, and might the problem is coming from there. My sincere advice is do not jump on foot and ankle, especially in poliotics. First, evaluate higher up. I will further elaborate these things. Let's take a case. This young person who wants to leave the crutch, hanging lower limb. Polio deformity correction is, I think, mother of all the deformity corrections. Multiple lower limb joints they are involved, maybe both sides are involved, muscles are also involved. No research or literature is there. There is dynamic worsening post polio syndrome, and it is a non glamorous job. Nobody wants to listen about it, and nobody wants to speak about it. I did in this muscle charting, did full length x rays, did CT scan, then I try to evaluate that right lower limb is involved, hip, thigh, knee, leg, and is it the bone, it is the joint or the soft tissue or the muscle? Then we also decide whether everything is to be resolved acutely or part of that acute rest gradually. Sorry. In this case, we did flexor abductor release, we did lateral popliteal nerve release, we did hamstring release, we did intertrochanteric osteotomy, we did supracondylar osteotomy, and this is the clinical picture after 3 months. The limb was straightened with the help of Elizro and Hexapol, and intertrochanteric osteotomy united. There was full extension of the knee. Supracondylar also was united, and these are the results. He could walk without the help of any stick or caliper or any kind of special shoes. He was referred by this doctor who wanted to leave the stick. Few words about lengthening in poliotics. This can be done at the intertrochanteric osteotomy level, supracondylar osteotomy level. This can be done even at the leg HTO, upper tibial level, and this can be done even at the supramalleolar osteotomy level. To elaborate lengthenings in a slight deeper sense, let's take the example of a 44-year-old lady who had post-polio left lower limb with foot and ankle issues. These are the video gate studies of the same lady. Since last 2.5 years, she is deteriorating day by day. Distance to which she could walk is decreasing slowly. On standing and walking, she is getting tired. There is fear of fall. There's even pain in the right lower limb on walking. She was referred by family physician in USA to podiatrist, foot and ankle surgeon. One suggested triple orthodesis. Other said TA lengthening. The other said TA lengthening is contraindicated. Go to the person who did the lengthening. And then they consulted the fourth foot and ankle surgeon and in the institution of Sir Professor Hasenberg, sir, who did the lengthening of the leg. Once Dr. Noman Siddiqui of the same institution told them foot and ankle surgery, they came to Professor Hasenberg, sir, and Hasenberg, sir, said, he, Dr. Noman Siddiqui is a very good doctor, but he is not right person for you or poliotic patient. Consult Dr. Anil Bhave, a senior physiotherapist who belongs to India, where large number of these patients are there. So ultimately, he landed up in my institution. He was operated upon 15 years back for lengthening of the leg. The PPT which I made was 66. This was giving rise to FFT. There was also August because MPTA was 93. The muscle charting was done. The heel was broad with zero TA power. There was equinus. She was walking on the forefoot. And there was pain in the foot. And I started looking proximally. There was FFD of the knee. Still, I went proximally and there was proximally FFD of the hip. I found there was 10 degree of FFD with slight valgus of the knee. I also did CT scans and found there was anteversion of the neck of the femur. And after that, I performed supracondylar osteotomy to resolve FFD of knee, valgus of knee, femoral rotation, and these are the pictures after that. The heel started touching ground. The foot became plantigrade. The knee became locked. And these are the pictures which she has sent me few days back. I requested her that I want to present the case, and she has. She has been benefited a lot because heel has started touching the ground. On standing and walking, fully plantigrade foot is there. Knee is locking. Both the lower limbs, they are taking equal loads on standing and walking. Hip is locking on standing and walking. Other limb is not in pain while walking and standing. And foot ankle pain has disappeared. The carry home message is polio surgical intervention involves surgeries at different levels. I suggested foot and ankle surgery can be done even later on if need be. And it is about 3 years back we did the surgery. Till now, there's no need of foot and ankle surgery. Second carry home message is before intervening foot and ankle, you must look and resolve knee and hip. And the third is lengthening in poliotics should not be taken lightly. This thing has been underlined by Revered Mangalsar in various conferences at various platforms time and again. What is the difference between an orthopedic surgeon and elizro and deformity correction surgeon? Let's take this case. Here, 23-year male is suffering from fracture shaft of the femur and he is a poliotic. I assessed that along with the fracture, he must be having FFT of the knee, which he was having. So I tried to resolve that. I did supracondylar osteotomy to resolve the FFT of the knee and as well as applied Hildesro and Hexapod to align the fracture. This is fracture which is being aligned by the hexapod and This is with the head support, we are correcting the flexion deformity of the knee. So in the same period in which the fracture had to unite, we have corrected the deformity as well. Another case, she never touched the ground with the involved lower limb, and she's an inspiration. She could walk without any stick, without any kind of shoe, and in this case, we did supracondylar osteotomy, intertrochanteric osteotomy, lengthening of the leg with soft tissue correction, and it took about 2 years to complete all these procedures. And dear friend, you can see in the frontal plane, knee is AP and ankle is lateral. At that level, we never knew that rotational issues they are there. Otherwise, we would have corrected that at the region rate. He's a doctor by profession, hand-thigh gait, very common, almost synonymous with the poliotic gait. Lengthening at the supracondylar level, also resolving the hand-thigh gait as well as length of the patient. Hardly any muscle is there which can be transferred in these poliotics, as you see. These adults, these are the results after 15 years. He can go up and climb up as well as down the stairs without any help. And there's no particular shoe or caliper and any kind of help. 13 years after the surgery, 12 years after hand-thigh gait resolving, 15 years after hand-thigh gait resolving, 14 years after the hand-thigh gait resolving, 5 years after the hand-thigh gait resolving. Earlier, we used to say no to an obese person. And these are the results after 4 years. No hand-thigh gait. Sorry. 10 years after the hand-thigh. Excuse. And bilateral cases, we used to refuse them. No, bilateral, we don't. Now we are taking bilateral as well. 2 years after, 6 months after the hand-thigh gait. Bilateral, she has to have stick and some support in other limb as well, upper limb as well. And after 3 years, you can see she can walk without support of anything. He's another doctor by profession, 2 years after the surgery. And there's no happiness which is greater than the good results of yours. This patient address from Canada after 4 years. One fine morning, he sent me a photograph with his hands raised, telling me that he can walk without hand-thigh gait. So, dear friends, no more stick. Genu recurvatum, genu valgum as well as recurvatum. And the same patient, genu recurvatum, the same patient, equinus cavus corrected. If the upper story, I mean to say, above knee, hip, leg, they are okay, you can resolve them even in one sitting without illusory. The same kind of a patient. Here she came for foot and ankle surgery, 50 years old lady, and we found that the knee and hip, they were also at fault. So we did supracondylar osteotomy as well as later on did patellar fusion. She came from UK and using crutches on both the sides. She could walk without help of any crutch or any kind of special shoe. She was also having bilateral, almost hanging lower limbs and only one side was done, left side, which was more involved, and she could walk. One side is still to be done. Single surgery which can change the life of the patient has to be thought of. In this lady was almost on the bed, bilateral. We used to refuse them. We thought by just doing a foot and ankle can change her life. What more we are doing? We are doing foot ankle fusions along with supracondylar posture. We are titrating so that there's no equinus which can lead on to recovertamapani. Also, there is no calcaneus which can buckle the knee joint while walking. So we are titrating these things now, and the results are bilateral lower limb. Both the lower limbs are there. He is from Madras. He went to Apollo Hospital. In 1991, I went to Apollo Hospital, Madras, and I used to see the corridors full of Ilizro. And he said me that he went there and they said, we have done politics with Ilizro and found that this Ilizro is not fit for politics. So in this, you can see he can walk even without the help of anything. The same kind of thing, foot ankle fusion with knee resolving. Single surgery, which can change the life of the patient. 3 steps, and she has to stand with hand thigh gait on the one side and sport on the other side. Sorry, we did only and only soft tissue surgeries, and you can see she can walk much better without any kind of sport of any other person or hand thigh. So you have to resolve what single surgery or two surgeries or three surgery in one go in first attempt, because most of the patient won't come for second surgery. Few lines about supramalleolar surgery which can resolve the rotation or instability of the foot and ankle and lengthening. You see, the supramalleolar osteotomy does the same thing as supracondylar osteotomy does for the knee. Supramalleolar does for the foot and ankle. Deformity correction in poliotic lower limb revolves around addressing correction in frontal, sagittal, and horizontal plane with the help of hip intertrochanteric osteotomy, osteotomies around the knee, supracondylar, and HTO. Sorry, supramalleolar osteotomy, osteotomies and fusions of the foot and ankle with soft tissue surgeries of the lower limb, as well as lengthenings. So, dear friend, this is in nutshell the chart of operations, and with carry home message that polio and post-polio syndrome, they are very commonly seen, mostly neglected, undiagnosed, untreated entity. It can be treated. Polio is eradicated. Yes. Is it myth? No, it's true. But the deformities are there. These are the sorry, sorry. These are very rare pictures. How these children they are developing hand thigh gaits. Basically, this is neglected pediatric orthopedics, which turn into adult deformities, and then it is to be taken up. This is 2014, not very far off. These children will become adult and will be treated. Very rare. kind of picture, hand thigh gait. How they are developing different types of hand thigh gaits. Different type from India, Bareilly. And we say polio is eradicated. But there are patients. The corridors you see are empty. There are no more patients. But they are there. They are in need of some sort of intervention to improve their function. So please listen to them in future, guide them, encourage them for surgery. They need surgery and they can be benefited. Thank you very much, dear friends, for your patience, listening, and giving your valuable time to me. But this presentation has a foundation which was laid upon by Dr. R.A. Agarwal sir. I am indebted to him and I bow down to him. He accepted to come to my institution 15 times, told me everything about erythropoiesis in a most gentle and humble form. Thank you very much, sir. And I'm also indebted to Mangal sir, who had been kind enough. And my first surgery in November 14, 2004, in my hospital, erythro surgery was done by him. He was kind enough to come. It was a upper and tibia shattered, comminuted fracture. And he applied the fixator, erythro, and the patient gained full motion after. Thank you very much, sir. And I requested you to kindly do something so that I can understand deformities and pursue this field. I never knew that one day I will only and only be doing erythro. So nice of you, sir. Your vibes are great. I'm also indebted to late Professor Ustenso, to whom I met at Dr. R.A. Agarwal's hospital. He knew everything which an orthopedic surgeon should know about poliotic treatments. His knowledge in the subject was immense, and I had the opportunity to talk to him and share the knowledge of him for today. Thank you very much, sir. And sorry, I am really indebted to Professor Solomon Leonid, who came on my request to my institution thrice. Each and every case, each and every part of the erythro and hexapod on each and every patient was discussed at length. Thank you very much, sir, for teaching me. And he's a friend of Dr. His friend, my Dr. Pankaj Bhatia. I went to him and he told me how to apply erythro first time in a tibia, which after going to his institution and learning, I came to my hospital and applied independent erythro. Thank you very much, Pankaj the Great. And I am really indebted to Dr. Vasudevan for his Palakkad courses, which I attended in 2011. And once I attended, I still remember I learned how to apply conical washers. I started erythro in 2005, and in 2011, after attending his course, I learned how to apply the conical washer. Secondly, there was a lecture by Mangal sir on hexapod. I got ignited I then purchased Hexapod, and all my patients were benefit of this. So nice of you. With these words, I thank everybody who paid attention and spared time for my presentation. And also, once again, I thank ASAMI and its team for giving me the opportunity. Thank you very much. कहाँ है? शेयर कर दो।